Welcome back, class. We're going to finish up our discussion of the institutional setting or the facility setting or the hospital setting, again, depending on the terminology you like to use, with this third segment. And Dewars talks about private hospitals appear to be more efficient than public hospitals. If you've ever been involved with public hospitals, it doesn't take a lot of research to see that this is true. When I worked at HealthNet, we did a lot of business in the DoD VA space. And because of the military, they require a readiness component that negatively impacts efficiency. So when I got to San Diego, I would, been out of graduate school, gone to work at Economic Research Service for a while, and then got back into healthcare and moved to San Diego. And my wife happened to be in the Department of Healthcare Planning at Naval Medical Center at San Diego. We were, I was down there talking to her and, talking with her one day. And actually, I'd gone down to meet her for lunch, but we were talking, and one of the OBGYN docs were there, and he was talking about, the number of deliveries they made each one, average on a monthly basis. And it was something like, I don't know, 20 or something. And I'm thinking, man, at Ohio State, when I worked at the hospital, you had, especially residents and interns, they were doing, maybe, 40, 45, 50 deliveries a month. And I'm thinking, what's the deal here? And, I said something to him, and he said, well, there's a readiness component, and, there's certain things we have to do to be ready in case, we have to go to war. So it just negatively impacts our efficiency and productivity. And you'll get the same story with, with the VA. You'll get the same story with, community hospitals. So there does tend to be, if it's a private hospital, of course, most private hospitals are driven by what? Driven by profit, driven by revenue. And so when profit's concerned, or when profit is a factor, hospitals tend to be more efficient. Utility maximization is an alternative model to profit maximization. And profit maximization is, it's just to me, it's just a special form of utility maximization. Residual earnings and observable outcomes. That's what's going to drive profit maximization. Hospital administrators for not-for-profit hospitals may maximize utilities subject to break-even constraints. Not-for-profit hospitals, they have a budget constraint just like the rest of us. I'm guessing that Meharry Medical Center is a not-for-profit. I don't know. I haven't really, don't really know anybody at Meharry, but I do know it's across the street from Fisk, and but I'm assuming it's a not-for-profit. And when they talk about it, that pecuniary is basically money driven by profit. In non-pecuniary, it's prestige or authority of position or benefits you receive. I'm sure there is a lot of prestige associated with Meharry Medical Center or associated with Vanderbilt in the national market. And some of those CEOs and administrators may be driven by non-monetary parameters and non-monetary factors. See, I've lost my train of thought here. Output and quality, largest and the highest quality hospitals given resources. So again, hospitals especially, it goes back to, they're just like everybody else. They have a certain budget constraint. Whether you're at Meharry, whether you're at Vanderbilt, you're at St. Thomas, can't think of the other hospital names in Nashville, but you have a budget constraint. And the CEOs or the presidents or the chief administrators or whatever title they're going by, they have to make choices based on the services they provide, and it's all driven by their budget constraints. So it depends on whether you're for profit or not for profit. If you're for profit, you're really going to be held to your budget constraint. If you're not for profit, you may just want, administrators may say, well, if I can just break even, or if I can make just a little profit, I can do so much more for public efficiency or public good or serving an indigent population. And so what drives their utility in the CEO's mind, their utility, it could be quality, it could be serving a needy population, could be profit. You just don't know what is actually driving the decisions that they make. Quality maximizing is variant to support of other functions and other objectives. Consumers demand quality. There are technology investments involved, and the distribution of provider and services. Again, distribution of provider and services are foremost on most hospital CEOs' mind. How do they, and again, it goes back to there's three pillars of economic thought that we've talked about before: opportunity cost, right? Optimization or self-interest, and making decisions at the margin. And if you're a CEO of a hospital or you're a manager of a medical group, or if you're in a leadership capacity in a health plan, you're all functioning using those three pillars. And so the CEO at Meharry is constantly looking at, how do I optimize the parameters that are set forth by, say, the board of directors? What are the opportunity costs, or what's the next best opportunity for me to utilize these resources? And at the margin, what makes the most sense to that consuming population that we're trying to provide services for? And then the next slide, we're talking about admitting physicians. They maximize their time and revenue, but maybe not the hospital efficiency. So surgeons especially, if you have orthopedic, cardiology, neurological surgeons, they are definitely the tail that wags the dog, and they are going to optimize their time is extremely valuable, and they are going to optimize that time, especially from a surgical perspective. So they are going to get, in most hospitals, they're going to get the primo surgical time. So they're going to tell the hospital, if you want me to refer my patients here, here's the surgical times I want. And if you don't give me these surgical times, I'll take and refer my patients somewhere else. And that's different than a staff physician. A staff physician, for the most part, is salaried by the hospital. And typically now they're calling them hospitalists, but, provided by the hospital. And they will, and at that point, it's the hospital that's, they're going to be the tail wagging the dog of these staff physicians. Excess hospital capacity enables physicians to maximize their own time. Hospitals got excess capacity. They're trying to fill beds. They're going to bend over backwards to ensure that the physicians that are referring to their hospital are receiving preferential treatment. To some extent, you'll call it preferential treatment, but they're going to receive the benefits of scheduling their procedures or admitting their patients at times when it benefits their schedule, because again, their time is extremely valuable. Physician control leads to technical efficiency and production, additional inputs, and then additional inputs are factors of production. You can use interns and residents to offset some of the workload of some of these staff physicians, which economizes their own time. Or the admitting physicians are going to use those residents and interns to, do rounds or or to check in to see how surgical patients are doing, or check in to see how the medical inpatients, maybe they are um, you've been admitted because you have chest pains and they just have you in there looking. So they're going to use these admitting physicians. Their time is extremely valuable, so they may use residents and interns to take care of some of that work for them. Hospital to provide complementary services, outpatient preventive care, reduces the risk of non-paying patients and mitigates the time of intensive services. So hospitals are getting more and more into kind of the prevention or population health type services, because it's going to ensure that the resources, and they are scarce resources, that these hospitals control, that they're going to be used for the highest intensity patients. And in return for high intensity patients, they're going to generate more revenue. Physicians and hospitals service priced separately. Physicians not accountable to the hospital nor to the consumer. So when they say their services are priced separately, let's say I go into the hospital and let's say I go into the emergency room and I've got acute appendicitis. So I go in the emergency room and I'm going to generate an emergency room visit. I'm going to maybe an observation room visit, depending on how long they keep me hanging around trying to figure out what's really going on, even though my side's killing me and I'm vomiting. I've got a temperature. I mean, everything points to appendicitis, but because of the litigious environment that healthcare functions in, they want to make sure. So they're just generating different kinds of bill charges and some X-rays and some labs, and then they finally decide that probably right before my appendix burst, they decide that they're going to take me in and operate. So I've got a physician that's going to, the surgeon that's going to generate a bill. He may have an assistant, or he or she may have an assistant surgeon that may generate a bill. Anesthesiologist is going to generate a bill. So at the end of the day, when you go in for a procedure in the hospital, it's going to generate multiple bills, either to you if you're a private payer, or to the in most instances to the health plan, or to Medicare, or to Medicaid, depending on what type of benefit plan you have. It's going to generate a bunch of services. Hospital services is going to come in on that UB04. Anesthesiology, the surgeon, maybe the assistant surgeon, that comes in on that CMS 1500. So there's going to be multiple bills generated. And then Duars talks about multi-hospital and fully integrated healthcare systems. Most are local or regional. And that is true to a certain extent. If I think of multi-hospital, fully integrated health systems, again, Buffalo, it was Mercy and Kaleida. If you're in Nashville, have you ever heard of Hospital Corporation of America, HCA? What, 2 miles? I passed by their campus, mile and a half, 2 miles from Fisk campus. Hospital Corporation of America, it's a for-profit, and they manage hospitals scattered all across the United States. Horizontal integration, which horizontal integration basically means 2 or more firms making same or similar products, and so you've got this horizontal integration, and you end up with economies of scale. Long-run average costs fall as operations expand, so more output, that long-run average cost falls. Again, remember, average cost, and it's long run, basically long run average total cost is made up of long run average variable cost and long run fixed cost, and that long run average total cost is going to fall the more output you generate. And one of the things that you see in this horizontal integration is that long run average total cost falls as output demands because you're reducing administrative overhead or SG&A, depending on what your accountants want to call it. You've got access to more information. You've got now, rather than just one hospital's information, you've got maybe multi hospitals in a situation in a multi hospital system that's generating information. You've got integration of services, everything. From an economies of scale perspective, everything just in theory starts to fall together. Assuming again that you're efficient and you're providing services in a resource efficient manner. Improved efficiency implies multiple technical advantages must occur. And that's true. You've got to have the technology to generate these advantages. And here's where the wrinkle gets a little hinky. And remember, go back to mutual interdependence. Antitrust views efficiency, branding, and imaging, pricing tendencies. Advertising promotes a perception of standardized quality across all facilities in the system. So if you're in a system, so let's go back to Buffalo. I've got Mercy, I've got Kaleida, the two huge systems in town. The two CEOs, or, male or female. I'm not even sure who the CEO is on either one of the systems anymore. But the two CEOs go to the same charity events. They belong to the same medical associations, maybe. Their kids may go to school together. They may belong to the same country club, whether they play golf together or not. Maybe they play golf on a Saturday afternoon and they both end up in the 19th hole to have a drink or something. And they start talking. A little business comes in and they start chitty-chatting about, pricing and, Blue Cross Blue Shield is, getting really aggressive on their pricing. And what are we going to do about that? And, they may not exchange particulars, but enough information flows back and forth that each CEO has a pretty good idea of what's going on within the healthcare environment within the Buffalo community. Antitrust is extremely difficult to prove and to prosecute, but again, mutual interdependence. The decision that Kaleida makes impacts Mercy. The decision Mercy makes impacts Kaleida, not only on the negotiation strategy, but on the services provided, where they're drawing members from. Kind of an incestuous environment to some extent. So I don't know. Healthcare, and don't get me wrong, it's not just on the provider side, it's on the health plan side. You've got individuals floating back and forth between Excellus and Blue Cross Blue Shield or Highmark now, since they've merged together, and the regional health plans. You see each other at the grocery store, playing golf together, kids definitely going to the same schools together. So there's just a lot of information that it's exchanged, and you're never going to be able, I can't say never, it's going to be extremely difficult to prove antitrust in any of this, but information is changing hands, constantly. And then on the last slide, DeWars talks about consumer access to quality and service information and aligning with respected hospital chains drives increasing demand and higher margins with respect to cost. Again, demand. What is that demand? If you've got a monopoly, remember we talked about monopolies, a downward sloping demand curve. If you've got an oligopoly, it's going to be a downward sloping demand curve. If it were a pure competitive market, that demand curve would be horizontal. The spot price would be the spot price. If it was a purely competitive market, the cost of a total knee replacement would be I don't know, 20,000 bucks. Let's say 20,000 bucks. And every surgeon in that market, if it was pure competition, would get 20,000 bucks because that is the supply and demand. That is the equilibrium price that's set by the market on supply and demand. If you're a monopolist or if you're an oligopolist, a monopolist especially, you're going to set the quantity, you're going to set the price based on marginal cost and marginal revenue and your downward sloping demand curve. Oligopoly, similar, not the exact approach, but similar approach. So enough brand power or enough market power is going to allow the oligopolists to set their prices. Does Kaleida have more brand power or market power than Mercy? If they do, they have an advantage in the negotiation process and an advantage in trying to set the prices that they receive for their goods or services. For-profit hospitals seek out lucrative niche markets insulated from competition. Again, nobody wants competition. If you can be insulated from competition, you can set your own equilibrium price and quantity. Economies to scale and expansion capacity. If you've got in a market that has barriers to entry, you can expand, you can control the market. Again, you're the 800-pound gorilla in that market. Not-for-profit hospitals seek high managed care organization penetration, more likely to compete and negotiate with MCOs, with managed care organizations. Not-for-profits, since they aren't theoretically driven by profit maximizations, they like to have partnerships with managed care organizations because they can, at least in theory, get a flow of patients, can help generate demand by the managed care organizations sending patients their way because they're willing to negotiate at a lower rate. Consolidated activity challenges antitrust policy. The government's going to continue to look at this antitrust policy. I don't know whether they've looked at HCA or not. Don't have a clue. But if the government starts sniffing around with antitrust, they could cause problems for again, when you're talking about horizontal integration or multi-system type healthcare units, nobody wants to be in an antitrust situation. That's going to wind it up for kind of the hospital section of Dewar's text, and hope everybody enjoyed it, and we'll touch base soon. Thanks. Bye.